Good evening, everyone. Thank you for joining us today. April, as some of you are aware, is Parkinson's Awareness Month, and 11th April is World Parkinson's Day. This time, we are discussing the topic of deep brain stimulation, or DBS, for Parkinson's disease, whether it is the right choice, for whom is it the right choice, when is it the right choice. We are very privileged to have with us a panel of persons with Parkinson's as well as neurologists. We've got I'm Aparna Mittal. I'm the moderator for this session and founder of Patients Engage. Dr. Shantipriya and Professor Pramesh Ratnakar are persons with Parkinson's. Dr. Shantipriya is an ophthalmologist, an artist, a patient advocate for persons with Parkinson's, founder of SAR Foundation, author of a book called Metamorphosis, as well as she's lived with Parkinson's for 14 years and with DBS for over 4 years. Professor Pramesh Ratnakar is a PhD in literature, a lifelong learner, teacher, and sports person living with PD for over 11 years, and he's just finished a 1-year anniversary of his DBS surgery. Both of them are young onset Parkinson's disease patients, and they are both generous with their time and insights. The two specialists that we have today are Dr. Petrus Vadia, who is a fellow in movement disorder and consultant neurologist and movement disorder specialist at Jaslok Hospital in Mumbai. He's been associated with PDMDS for a long time. I think he's one of the founder members, and he is very, very active in patient awareness and Parkinson's and other movement disorders. Dr. Rupa Rajan is a postdoctoral fellowship in movement disorders, additional professor, DBT Wellcome Trust, India Alliance Intermediate Fellow, and she's at AIMS in the Department of Neurology. A quick reminder, Patients Engage is an online platform for patients dealing with chronic diseases and their caregivers to share personal experiences, information, and learn from each other and healthcare professionals. The whole objective being the better informed we are, the better decisions we will make, and we will feel confident about those decisions as well. Plus, also, we don't feel alone because there are others who've been through this situation. Sorry. Previously, we have done a few webinars with persons with Parkinson's. We've talked on transforming personally with Parkinson's disease. Earlier, we've talked of living better with Parkinson's, with PDMDS as a partner. And we talked of what people who have young onset Parkinson's go through as well. So, these are some of our earlier webinars. You will find them on our YouTube channel. And you will find a host of website content where people with Parkinson's have shared their experiences, plus there's a lot of other information on it. Some of these people have also written books. Again, you'll find references to those books on the website. Quick reminder that the views expressed in the video are of the panelists and are only meant for general awareness. They do not replace a medical consultation. So please do consult your doctor or any of these doctors separately for specific medical issues. As well as the patient's experiences are unique. So keep that in mind. There's a lot to learn from them, but you should always discuss with your doctor specifically to yourself. And you can always contact us through our social media channels. We are on Facebook, Twitter, Instagram, YouTube, LinkedIn, and our website is www.patientsengage.com. So let me get started. Thank you, everyone, for joining us today. Let me start with you, Dr. Vadia. What is deep brain stimulation?
So deep brain stimulation is basically something that's been around since as early as 1993. We have finished 30 years of deep brain stimulation in the world. So it's an established therapy option. When I say therapy option, it is not a cure. It is a treatment option, basically improving symptoms and quality of life of patients where it is done. Now, deep brain stimulation is done for Parkinson's. It's also done for other diseases. including dystonia, tremor, and it is also being used in certain psychiatric disorders and also being explored in patients with refractory epilepsy. So there are a lot of indications for DBS. Today, we are going to talk mainly about Parkinson's disease. In Parkinson's disease, basically DBS involves putting two electrodes in the brain. Um, the usual location where it is put is either the subthalamic nucleus, STN for short, or globus pallidus internus, GPI for short. Now, there are advantages and disadvantages of choosing either location, but I think that's a little bit technical. STN, the advantage is you're able to reduce your medication, so you also reduce the medication side effect. STN being a smaller target, you require less amount of current, so your battery longevity is better. But now with rechargeable batteries, which last for 25 years, I think the battery longevity is probably a secondary importance. It's not as much as it was a stress when we were probably in the early 2000s, where the batteries were all 3 and 4 years and you had to go on changing it. And it was a
Right.
recurring expense. And also, of course, the pain of undergoing a surgery again and again.
Correct. So thank you, Dr. Wadia. Dr. Rupa, in your experience, when is DBS? We know the types of neurological conditions for which DBS is appropriate, but when in the life cycle of a patient is DBS considered appropriate?
Yes, so the timing of surgery is it is a very important aspect of when you decide to go for or against DBS. So first of all, if we talk about Parkinson's disease is one of the causes of what we call Parkinsonism, right? Parkinsonism is a symptom complex. So it can be Parkinson's disease is the commonest cause, but it may be other causes of Parkinsonism, such as, atypical Parkinsonism disorders like we call it PSP or CBD. Sometimes Parkinsonism can be drug-induced. Sometimes it can be the result of some strategic strokes or small infarcts in the brain. So DBS is considered only in patients with typical Parkinson's disease. So, and in patients with typical Parkinson's disease, what usually happens is that Parkinson's disease, in the initial few years, they get very good benefit from the medications used to treat Parkinson's disease. The symptoms are very well controlled and near normal quality of life is achievable with medications in the early years. But with passage of time, the effects of these medicines start wearing off. In technical terms, we call these motor complications or motor fluctuations, where the effect starts wearing off, or there are some abnormal, unwanted, maybe dance-like movements start appearing. And it is at this point of time that one starts to consider DBS. Generally, DBS is indicated in patients with Parkinson's disease who experience motor fluctuations despite optimal medical therapy. So the first step when these fluctuations start happening is to adjust the medications. So for several years, we may be able to manage these symptoms by making medication adjustments. But despite these medication adjustments, when the symptoms become functionally disabling, this is the time that one should consider surgery. So there is no absolute rule about the years, or generally it is considered after at least 4 years of Parkinson's disease, because we want to be sure that this is not an atypical Parkinsonism or not a drug-induced Parkinsonism. And any time after the onset of fluctuations, if they are bothersome and affecting the patient's quality of life in either professionally, socially, or in the day-to-day activities, if these are becoming limiting factors, one can consider surgery. Right. Usually, it is considered in people who are taking at least 4 to 5, more than 5 times medications in a day. And despite that, if there is off time of at least 1.5 hours, or there are these abnormal unwanted movements, then one can consider.
Right. Dr. Wadia, what is the limit? Is there an age limit? Because I think in our case, both our panelists are young onset and therefore younger. But is there an age limit, or is there a fitness criteria that you look at? Can it be too late for DBS? How do you determine and how do you advise patients on that?
So I mean, when DBS started out, I think people had put an RBIT criteria of 70. But
Hmm.
it's not that when you are 71, you turn into a pumpkin and you cannot have DBS. So it's very difficult to say that this is an absolute cutoff age. But at the same time, if you look at the results of DBS in significantly older patients, the results are not as robust as they are for younger patients. So I would still think that you have to have some kind of an age cutoff in the mind. And most people think 74, 75 is sort of where you're pushing your limit.
Hmm.
More than the age criteria is actually a cognitive criteria.
Right.
You have to have no significant cognitive impairment. There should
Right.
be no dementia for sure. And even mild cognitive impairment does affect your DBS result. So it's not that as a palliative care option, you don't offer DBS to people with mild cognitive impairment, but you have to discuss it with the patient and the family and tell them that you may not get the desired result you're looking for
Hmm.
because you're cognitively not good. Because if you're cognitively not good, it's very difficult to even cooperate for the post-operative programming. And cognition plays a very important part of the way we learn to walk. And
Right.
your main outcome of DBS is eventually walking, falling, freezing. So if you have significant cognitive impairment, the results of your DBS are going to be much less than what they would have been had there been no cognitive impairment. So I
Right.
mean,
Right.
you can either live in the ideal world, which is like a clinical trial where you take only the perfect patient and take him for surgery, or you can expand it and take the not so perfect patient. But I think when you take the not so perfect patient, you've got to be very clear in your mind that they understand that they are
Hmm.
these are the limitations in their patient selection criteria, and they may not have as good as a result as DBS. Now, in
Right.
many parts of the world, there are options like levodopa gel, which we don't have in India. So
Hmm.
these options which are available abroad are not available to our patients. So if they were available, maybe some of these patients who are not so perfect, we could have taken them up and put them for gel therapy.
Right.
Subcutaneous levodopa has also just finished a randomized phase 3 trial. It's just published in the New England Journal of Medicine. And I think it promises to be a big alternative to DBS in those who are not good candidates for DBS. So I think we need
Excellent.
alternatives in
Correct.
those who are not candidates or those who refuse to have a procedure on their brain, which is normal.
Hmm.
I don't think everybody is like, yeah, I want a procedure on my brain.
Yeah. We will talk about that to the two panelists as well.
Yeah, so I mean, it's not by choice. It's just
Hmm.
because that is the best option for you. But there are certain people who are not candidates, and I think we need alternatives, which we don't have in a big way at the moment.
Right. Right.
But
Okay.
I think they're on the anvil. They will come.
Good, good. That's reassuring, and that's good to know. Let me start with you, Dr. Shantipriya. When did you first consider DBS, and how did you go about having that conversation with your physician? Did your physician suggest it? Did you take it up with your physician? And how long did that decision take?
Actually, around 2018 must be. I read a lot about DBS and I had a lot of motor fluctuations, crippling dystonia, on and off, and dyskinesias were troublesome. Because that's when I asked my doctor, not he didn't suggest, but I asked because I wanted a better quality of life. So that's when I thought about DBS, and it almost took a year to make myself prepared physically and mentally to undergo the surgery. And finally, in 2019, end of 2019, I had my deep brain stimulation.
So what were some of the fears that you kind of navigated, and how did you navigate those fears? How did you get to, as Dr. Wadia said, nobody likes the idea of something being done to their brain.
Yeah, because I was very adamant on having a better quality of life. That was the main criteria. But I was very anxious because it was an awake surgery. So that also took some time. That's why I had to think a lot whether
Right.
I'll be able to undergo it, whether I have the willpower to do it. But otherwise, because I needed a better quality of life, I said, okay,
You
I'm
went
doing
ahead.
it. Yes.
Right. Professor Pramesh,
You want me to
answer
start
the
off
same
by thanking
question.
you? You want me to start off by thanking you for calling me young? Or do you want me to start off by quoting Eliot by saying April is the cruelest month? Or do you start off by my fears, talking about my fears?
Your choice. Always
Okay,
your
I'll
choice.
start off by talking about my fears.
Hmm.
See, for me, Parkinson has been a lifelong experience. I mean, my grandfather had it, my father had it, I had it. So when I was diagnosed with Parkinson in 2013, I was terrified. I mean, I had seen the worst of it, and I'd seen what they'd gone through, and I knew that that was what was waiting for me at the end of the road. So I was literally terrified. And then, I think I was well on my way to depression in a certain sense. I was on a downward slope, and I was carrying on pretty rapidly. But then it's amazing actually. It's quite a story. I read an article, just random article, picked it up in Hindu, and it said things which made such a lot of sense to me that it changed my life completely. I mean, it said take charge of your life. Your body has enough to answer, and you can set it targets and goals, limited goals. It will respond. It will get back to you, and take advice from experts. But take your own calls. And that brought into play a whole lot of my own thinking, my own personality, my own attitude into action. Now, so far so good. And once I got going, I had a pretty good time, and the dopamine worked, and I climbed mountains, and I rollerbladed, and I did all kinds of things. So but after a few years down the line, that means after about 7-8 years after being diagnosed, I began to run out of steam. And the Syndopa was not having as much effect. I was on to 8 or 9 of them, and but even then I didn't want to go for DBS.
Correct.
I was determined not to go for DBS because I didn't want any tampering with the brain. I like Michael J. Fox's formulation when he says that I mean, if you can cure me, then I can let you have access to my brain. Otherwise, I don't mind shaking and dancing. If others get married, so what? But I developed a back pain which stopped everything. I mean, I lost weight, and it took me about a year to take my call for DBS because I was literally bedridden.
Right.
When I went for DBS, I mean, I was back pain and all that. So by the end of it all, I had no choice. And then I spoke to the surgeon, I spoke to my neurologist and all that, and everybody said that DBS would help. So I planned for it. I got retired from my job, and then I went for DBS, and I had nothing else to do. So I sort of focused on my health and went for it.
Right.
And the other element why I didn't want DBS was because I was fighting Parkinson through my brain, through my head, by redefining Parkinson, by looking at it in a different way. And I thought if I lose my identity, if I lose my ability to be myself, I mean, if somebody puts electrodes in the brain, then how do you be yourself? Then I might lose my ability to fight Parkinson as well.
Right.
So I think Dr. Rupa was right when she mentioned that you take some time, and when you are ready for it, and when you are completely convinced that it's okay, then you should go for it.
Right. Okay. So Dr. Rupa, I think we've talked of the fact that it is not a cure. So what can patients with Parkinson's expect after DBS? Are they expecting symptom management? What do they expect in terms of quality of life improvement?
Yes. So the expectations are that this entire concept of doing DBS is basically to improve the quality of life. As it has been already emphasized, it is not curative. It does not bring back the cells that are slowly reducing in the brain. It does not increase the dopamine levels, but with this electrical stimulation, the symptoms can be controlled in a better manner than is possible with medications alone. And with that, the quality of life can be improved. So what one can expect is basically improvement in the motor symptoms of Parkinson's disease. So the cardinal motor symptoms, the movement-related symptoms like tremor, slowness, stiffness, these generally improve to the tune of somewhere between 70 to 90%. It's not 100%. Tremor usually improves with, say, ST and DBS. With GPI, DBS also, maybe it takes a little bit more time to control the tremor, but tremor control rates of up to 90% one can expect. We can expect the slowness and stiffness to improve about around 70 to 80%. And medications, especially after subthalamic nucleus DBS, we can reduce the medications to around 50 to 70%. The goal of surgery is not to take away the medications completely, and it's not something that we actively pursue because as has been highlighted, medications, dopamine to a certain extent is very important for good mood, for your memory, for walking. So we don't want to take it away completely, but about 50 to 70% reduction in medications. And when we reduce the medications, the dyskinesias or the abnormal involuntary movements, these also reduce by about 90% around. So these are the 5 symptoms that we generally expect to improve: tremor, slowness, stiffness, medication reduction, and dyskinesias. There are some other symptoms that may improve as a corollary of this. For example, pain, as was discussed by Professor Pramesh. Sometimes this can be a very disabling off-time symptom. So when the off time goes away, pain, maybe literature says about 60%, 60-70% of patients get pain relief. Sometimes the sleep quality can improve when the nocturnal, the off times reduce. But DBS is not done primarily for these indications. It is primarily done for motor symptoms, but some non-motor symptoms may also improve. And there are also some, it's also important equally to know what doesn't improve. So there are some limitations. So as discussed by Dr. Petrus earlier, memory is something that we are very concerned about. Memory usually does not improve. It doesn't improve after surgery. And we do a very detailed cognitive assessment before surgery to assess the fitness. And with ST and DBS, we do know that some of those tests, particular tests, if we repeat it at 6 months, the value, the scores can go down. But it is not enough to cause any clinically significant cognitive problems. But for people who are, for example, professors, or for whom writing, reading, verbal fluency skills are very important, this is something that we speak upfront. Gait doesn't usually improve after surgery unless it improves with medications. So medication refractory, the gait problems, freezing, that is improving in the on time. We can expect that at least for a certain period of time. This may also improve after surgery. But if it doesn't improve with medications, if you have significant freezing of gait, imbalance during on time as well, these problems don't usually go away after surgery. So these are some limitations. Also BP fluctuations, bladder control. So these are generally very late manifestations in Parkinson's disease, and DBS is best done in that window period when once the fluctuations start and before these advanced symptoms appear. And that's why young onset patients are generally good candidates, because they develop these advanced milestones much later compared to later onset patients. Yes.
So, Dr. Wadia, from patients who may be considering this, or families that are considering this, what would you tell them are the potential risks? We've talked of the benefits, we've talked of quality of life improvement. What should they keep in mind in terms of the risks of DBS?
So the biggest and most fearful risk is the risk of brain hemorrhage. That risk, when we began DBS, I think in 1993, was about 5%. But that's because we were also having, at that time, even MRIs were new to the world. And we were running protocols based on CT scan where you can't see the blood vessels. Today, with pre-Tesla MRIs, and our protocol in our institute is to do it under general anesthesia, so that there is absolutely no movement that's occurring during the MRI. You actually can visualize the blood vessels. You can visualize and you can anticipate hemorrhage. So you actually bring that risk down from about 5% to about 1 to 2%.
Right.
But it's still a risk. But I think the number of hemorrhages from the beginning have come down substantially. The second risk is a risk of, apart from brain hemorrhage, there is a risk of infection. And there is about a risk, that risk of infection goes on as long as you live. There is an initial risk right in the perioperative period when you put electrodes in the brain. There is a risk of infection around the electrode. But subsequently, that risk is always there, because in case you scratch out, there's a wound infection, you can always get infected. And any implant, whether it's a hip replacement, knee replacement, any implant that gets infected, you have to literally remove the implant.
Right. And how are people supposed to manage that risk of infection? Dr. Wadia?
So the risk of infection, first you obviously treat it. I mean, you try to mitigate it by antibiotics, etc. But if it doesn't respond, you got to then probably remove the electrode.
Okay. Okay.
Right.
So, Professor Pramesh, when you were deciding, as you were approaching the decision on DBS, what was the information that you sought, and what was the information that you kind of was shared with you before the surgery? What kind of information did you look for?
No,
What kind of information did you?
I was fully aware of all the problems that the risks were listed out. And I remember that session, my wife was also there, and my doctor sort of went through the list of things, and we were very scared after that. But and they did mention that percentages, 5%, 2%, 3%, 1%, just that kind of thing. But you don't look at percentages. You look at you sort of vividly draw the picture of all the hassles that are there. But by the time you reach the stage for DBS, you are so badly off that you are willing to try anything. So there was no real stepping back from DBS, as it were. I mean, I'd already made up my mind that I want to get it done, and I don't know how often it happens with other patients that they've kind of made up their mind, even whatever doctors might say in terms of risk. Suppose they had said the risk was 15%, I would still have gone ahead with the DBS.
Right.
Dr. Shantipriya? Sorry.
One more thing I'll say. One more thing.
Sure.
One thing which was shared, which was very important, which I hope everyone else gets to hear this, because it was shared with me and it helped a lot. Immediately after DBS, there's some sort of a flowering period. I mean, I was much better off than in those 4, 5, 6 days immediately after DBS than I am now. So something happens, and I was told that this would happen and that you would come down from a very big high, as it were. And I was prepared for that. So that helped a lot. Otherwise, I could have got knocked off into some very, oh God, I've done something wrong, or I've done something terrible, that I was feeling so much better earlier and now I'm not feeling well enough.
Right. So, the kind of curve is explained to you, so you know what to expect.
Yeah.
Right. Dr. Shantipriya?
Yeah, as Professor Pramesh said, even I was very desperate for a better quality of life. So even though all the risks were explained, I was ready. I was already prepared to undergo this. And everything was explained. What you can do after DBS, before DBS, what you can expect, what, as Dr. Upan Wadia said, everything was clearly explained to me. That we should avoid MRI cannot be done, and scanners, you should be careful, no swimming. Everything was clearly explained.
Right.
But we are in desperation to do it. So you trust your doctor, neurologist and neurosurgeon, and go ahead.
Right. So coming to the surgery, I think both of them said, at least Dr. Shantipriya said that she was scared of it being awake during it. Dr. Vadia, is there, what happens during the surgery, and is there an option of not being awake?
Yes. So when DBS
I can't
began,
hear you. Is that me or?
no, can you hear me now?
Yes.
Or just me?
We can hear you. I can hear you.
Okay, go ahead.
Yeah. So when DBS began, it was always awake because at that time, as I told you, we didn't even have access to reasonably good quality MRIs. And they literally had to map out all the structures in the brain around the subthalamic nucleus
Now something
before
has
they
gone
actually
wrong.
put. Can you hear me?
Yeah, I can hear you.
Yeah.
Yeah,
It is-
even I can.
Okay. So basically, when it began, it was always awake because you had to actually map out the brain structures because of the lack of very high quality imaging. Subsequently, with high quality MRIs, there have been a mood to move to a sleep DBS in certain cases. So in those people who just can't lie flat or who are very anxious, we have done a sleep DBS. When you do DBS, you're doing 3 levels of check. You're first doing an anatomical check or a structural check, to put it in more layman's term, where you're looking at the structures of the brain. That is using your MRI. That is the same whether you're doing a sleep or awake DBS.
Right.
The second level of check is electrophysiological check, where you're actually trying to listen to the brain waves, which are signature differs whether it's subthalamic nucleus or the structure below, which is substantia nigra, or the structure which is above. And that tells you, yes, this is the spot that I would like my electrode to be in. Over and above that, so you have the structural check, you have the electrical check, then you have the clinical check. The clinical check is where actually in the operation theater, both the treating neurologist and the patient can actually experience an improvement in their Parkinson's disease on table. And I'm sure both the panelists who are here probably have experienced themselves. And believe me, it's a eureka moment for everybody. So I mean, you miss out on the last 2 steps, that is the electrical check and the clinical check. More the clinical check than the electrical check. In a sleep DBS, we are able to pull the anesthesia down, do sometimes get an electrical check, sometimes you don't. But more often than not, you get it if you have your protocol set correctly. But you cannot get the clinical check. Now, that information is not available to you. So your accuracy will suffer in a sleep DBS by a couple of millimeters here and there, which is less likely to occur in an awake DBS. It's nothing is zero. I mean, nothing has a 100% sigma accuracy. But your entire result of DBS depends on where your electrode is.
Right.
So a couple of millimeters deviation affects your future quality of life. So in my view, unless there are serious reasons why we can't do an awake DBS, which cannot be done if the person is 6-year-old in a dystonia or something like that. I mean, you cannot expect a 6-year-old child to be like super cooperative. I'm just giving an example. Unless there's really compelling reasons, I wouldn't want to do an sleep DBS. I'd rather have the patient awake so that, that little pain in the OR that we are going to deal with, we will be dealing with a better result for the years to come subsequently.
Right.
So it's not that there are no alternatives, but the alternatives come with a compromise.
And the outcomes are affected.
Well, there are proponents who believe that it's not such a big deal, but according to me, every millimeter counts.
Right. So both of you, right? Professor Pramesh, how do you remember your surgical experience? And I don't want the full, but
to be in short, I felt like a warrior with armor fighting a battle. It was a 12-hour ordeal. We had some technical glitches in between, which made me and my family standing outside was more anxious. But I don't know. Now I went through everything and everything is over.
Right.
That's what, in short, it's like a warrior, Parkinson's warrior fighting a battle.
Right.
And you win the battle.
And are family members allowed inside?
No, outside, because I had in
that?
between. No, even though I come from a family of doctors, none of them were allowed inside. Because I had a technical glitch in almost 2 hours. There were some mapping problem in the MRI. So I was in the theater lying there, don't know what to do. Only after when I came out, I knew all about it. Otherwise, I felt okay, went through it. But the burr rolling part was really terrible. Even though it's been more than 4 years since I had it, I still remember the burr hole. That is when you're drilling through the skull to enter the brain.
Right.
That was really terrible. It was like a sinking feeling you get. Something, you go in a dark tunnel and then suddenly there's some light or something.
And that eureka moment, what do you remember of that Dr. Wadia talked of?
Eureka moment was not during the surgery. It was after the surgery, which I felt.
Right.
You're so tired after that, you don't even data less to do all those tests on table for the surgery, move the legs and all. But you don't know how it is because you want to just finish it. Only the eureka moment was only after the next day of surgery.
Right. Okay. Professor Pramesh, you're on mute. You need to unmute yourself.
Okay. Sorry. Yeah. I was not told one thing. There's some sort of anesthesia is given, I believe. I don't know how and what stage it is given, but some sort of anesthesia is given. And I wasn't told that you can make an utter fool of yourself after having had the anesthesia. But you're slightly awake, and I remember quoting Shakespeare tomorrow and way to dusty death and all that kind of a thing. Nonsense. I was doing all that kind of a hysterical stuff. But and the anxiety was in a different sense was when I mean, jokes apart, when I was being asked to sort of say that when the finger was being moved or hand was being moved and how do you feel, I really didn't quite know whether I'm giving the right answer or not. And I knew that the answer would shape the placement of the electrode. So there can be issues about how the patient responds on the table. I mean, you can be and you don't know whether you are right or you're saying the right thing or the wrong thing, and then that will influence the rest of the thing as well. So I mean, that was a major anxiety.
So just to kind of give a parallel, right? Is it like the eye test where they say, is this better or is this better?
No, well, when they're very close to it.
Any of you.
Any of them could be better, and you don't know which one is better. And so that
sometimes.
Is,
sometimes, right.
But most of the time,
I wonder what the doctors have to say. I wonder what the doctors have to say.
I think Dr. Rupa is saying something.
Yeah, so I can, first of all, I have to, really appreciate the panelists, who have gone through this for coming forward with these experiences, because we as doctors, we can only imagine, or we can only, we can see it only from an outside perspective. So, but from the medical point of view, what we are actually looking at is most often we are looking at whether there is an improvement from the baseline.
Right.
This sometimes as Dr. Wadia discussed, we take some recordings and we place some recording and stimulating electrodes initially. So there are more than one of them. So it's often sometimes happens that when we stimulate on one, there is some benefit. And with the second electrode, then you don't have so much severe of a baseline difficulty for us to appreciate, a great magnitude of improvement as from the first stimulation. So in such situations, sometimes we may do, is this with a very cooperative patient, we may ask this question, is this channel better or is the other one? But otherwise, it is something that we objectively assess, the stiffness, the tremor going away. If these dyskinesias appear during stimulation, then we are generally happy to see that because that means, the current is, we are stimulating in the right place. Yes, I also say that, before the day of surgery, one of the important pre-operative assessments that we do is the medication off and on assessment. So I also tell my patients and the family that this is like a, it's like a prequel, or it's like a practice for the day. So we know that, you know how it is going to be without medications for such. So that helps them, I hope, be a little prepared about,
Right.
what are the expectations. And it's the same test that we do in that state, mostly similar that we do in the OT. So that way one can help them prepare. But yes, I can understand, and I'm sure Dr. Wadia also agrees that if there is another way of doing it, asleep with the same accuracy, we would welcome it. But as of now, I completely agree with what Dr. Wadia said, that we feel that, awake definitely gives us more information and a better, more confident placement than we are able to do under sleep.
Right. Thank you. Thank you, Dr. Rupa.
I think I'll just add a couple of points here, what Dr. Rupa said. So basically, while we do ask the patients at time that do you think that this is exactly how it is in your on phase or when you've taken your levodopa, I think we are also objectively assessing it. So I think the anxiety that Mr. Pramesh exerted, that what if I'm not giving the perfect answer, and what if the electrode went in the wrong place? So I think we understand the patient is pretty tired in this whole exercise. So while yes, we do look at some subjective responses, we really rely more on our own objective assessments. And usually in the OR, I don't know how it is. In most centers, there are at least 5 or 6 people in the OR. Everyone's looking keenly to see what's better or not. So it's not just one individual who's taking. Everyone's collectively looking at it. And so I think in the end, it's a collective, very calculated, thought out decision. It's not something that's done arbitrarily, and it's obviously done in the best interest of the patient. So I think we understand the patient can be like Shantipriya said, she just wanted to get over it. Like, I mean, she was so tired because of the technical glitch and all, and you're wearing a heavy frame, so it's exhausting.
Right.
So it is exhausting.
That frame and the drill sound is the amazing experience that lasts for a lifetime.
Right.
Right. So it is exhausting. So, but at the same time, there is a lot of information when the patient is awake, but we do understand that we cannot be entirely putting the responsibility on the patient's shoulders to tell us which one is better than the other.
Okay. So I think that's important for patients who are listening or considering to know that, the onus is not just fully on them, and they don't have to feel extremely stressed about this. I think if we look back after the surgery, there is this need for constant programming. So what are the protocols, frequencies for, the programming and adjustments? And I'll start with you, Dr. Rupa, first. And, again, what is optimum? How much can you fine tune, etc.?
So generally, if you look at most Indian centers, our practices may be a little different from what is followed in the West, where generally programming starts about a month or a few weeks after implanting the electrodes. But most Indian centers, including our center, we generally start a little earlier in the postoperative period during the admission for surgery. We start an initial programming at about 3-4 days after the surgery. At this time, basically, the electrodes, the contacts are reviewed for us to have a general idea where they are placed and which seem to be the better contacts with the least good benefit, at least current, and high threshold for any adverse events. So, we do something called a monopolar review. And then we start with very low currents, and then generally we discharge patients after about 5 to 7 days of surgery. And then we call them back at about a month to fine tune. And in between this 1 month, one can expect that the effects of surgery, we call these lesioning effects that Professor Pramesh alluded to. Because of these lesioning effects, there is a sort of a second honeymoon period where the symptoms of Parkinson's disease are really low, and but they slowly start making a comeback. And this we expect somewhere, it may take a few weeks to a few months. So once these surgical effects wane off and the previous symptoms start coming back, that is when we can optimize this programming. And that we do usually at about 4 to 6 weeks. And after that, in the first year, we ask for scheduled visits every 3 months or so. And beyond the first year, once in 6 months or even once in a year. If there are any pressing issues in between, of course, we call more frequently. Yeah.
Right. And Dr. Wadia, is self-adjustment, technology advancement that's coming in or already here, etc. Are there kind of technology?
So I think you have to realize that. So we do all programmers since I've been in DBS since 2006. So now I think I'm fossil.
You've seen the whole transition.
Yes, I've seen the entire metamorphosis of DBS. But if you look at it, all programmers came with the option of increasing or decreasing the stimulation current. We now, since 2013, have the option of setting 4 groups. So we give group 1, which is maybe your best group, and then you have 2, 3, 4 as optional groups. So especially in patients who live very far off, and this is something we've been doing even before COVID, before online consultation was like a big thing. We've been online consulting people who live very far out, so that you set alternative groups, give them groups so that they can add the groups in or change from group 1 to a group 2 if there's an issue. So even if you change the group or change the setting when they came for the follow-up visit, you always keep the old setting as backup.
Right.
So there is some degree of self-adjustment that you allow, but I think it has to be within limits.
Right.
You can't just give a carte blanche because the patient doesn't understand what the risks are. So if you overstimulate, you can actually cause side effects. You can cause side effects by the current spreading to normal, healthier areas of the brain. So you have to be within limits. So there are currently 2 systems which are available in the world, one from Abbott and one from Senior. None of them which really have a big presence in India, which allow you remote programming. Senior is a Chinese system, and I think we're very wary because we don't know when the government will regulate it. Otherwise, and the patients will have no support post-operatively.
Right.
Abbott hasn't entered India for God knows what reason. So both these systems are not available. They come with complete teleprogramming that the patient can be sitting in, for example, in Lucknow, and you could be in Mumbai or Delhi and completely programming him remotely. The current systems that we have, which are largely available to India, is mostly Medtronic and Boston, and none of them have remote programming as of now.
Right. So you addressed the issue because one of my questions was, how do people who are, kind of far away from tertiary care centers, how do they kind of handle ongoing management? Is there anything else that either of you would like to add on management for patients who are not situated, like both Dr. Shantipriya and Professor Pramesh are in metro cities, so it's been kind of easier for them, but for others who are further away, is there anything else that you would suggest or advise?
I agree with Professor Wadia that we tend to program different groups for these patients, and we tend to set some limits
Right.
in which patients can. And I think one important thing that we have patients from all over India, right from Ladakh to I think from to Kerala, we have patients. But the social support is important. So in that way, not just in terms of programming support, but in that first 4 to 6 weeks, it's extremely important that, and this is something that when we select patients, sometimes it's not a formal stated criteria, but to a large extent, patients are able to manage the programmer and adjustments themselves. But it helps to have someone, so
Right.
somebody who is a little bit tech savvy, who can at least in the initial few months handle the charging and the minor adjustments for programming. This is important, and it is when that is not available. Those are the situations where for remote patients we have had challenges. Otherwise, yeah.
Right. And Dr. Wadia,
Just one more point,
yeah,
I think, from Rupa. Rupa mentioned, I think, the social support very, very important. So, and also choosing your device becomes very important. So, for a person who's living alone, I would not choose a rechargeable device.
Yes.
Because imagine, I mean, if you are a person with Parkinson, you're going to have to deal with the stress of recharging your device. You just had a viral cough cold and you forgot to recharge your device. You become a statue. You can't move. So it is important that rechargeable devices are really put in people who have people living with them, social support, caregiver support. Otherwise, I think for people who live alone or live in nursing homes or assisted living centers, I think they need to be only on non-rechargeable devices. Even if it means you change the device in 5 years, it's better than having to have the stress. It's because it's an additional stress. Every week you got to remember to plug yourself in. And that's one more thing on the checklist which you really don't need to deal with.
Right. And in terms of the balance of how much you can do with programming versus needing to increase your medication, how does that balance work out?
So I think in the first year, you need a little more frequent checkups. So in fact, I think I'm sure Dr. Rupa also would have experienced, and most of us tell our patients that you need to come back within the first 3 months and be prepared to come back with the first 3 months, because the lesion effect going away. So basically, already been talked about, but basically it is swelling around the electrode. Now, if you had any injury, you hurt yourself, you'll get a little swelling around that little injury. So it's basically when you put your electrode in, there is a little injury to the brain, so there is a little swelling around it. That swelling actually makes your Parkinson's completely better. And that's what Professor Pramesh alluded to earlier. Now, when that swelling actually goes away, that time frame is variable. Some people it may take a year, some people 2 years, it can take a month, some people 2 months. So, unless that complete lesion effect goes away, your second programming visit will otherwise be the same as the first.
Right.
So you really need to revise your programming when that lesion effect goes away. And that time you really have to bring the patient in. And the drugs also come down proportional to how good your programming is helping your Parkinson's. So it's a balance that both has to be done. You have to adjust your settings as well as reduce your medication.
Right. Thank you. Just for those who just joined in, we're talking to our panel on whether DBS, under what circumstances deep brain stimulation is the right choice for Parkinson's patients. And we've been hearing from Dr. Petrus Wadia and Dr. Rupa Rajan, as well as persons with Parkinson's, Professor Pramesh and Dr. Shantipriya. Dr. Shantipriya, life after DBS, what did you go through? I know you said you had to give up on swimming, possibly. So what activities were restricted? What were the change in symptoms, effect on moods? You have these leads. There's a visual that you have that there are all these leads around initially, at least. So how do you manage with all of that?
The first 1 or 2 years, I didn't have, to start with, after DBS, I don't have a single episode of dystonia, which was really crippling in my case. That I don't have, and I don't have any on and off periods. So that was a relief. The first 1 year, all my motor symptoms were, I was almost felt like I was 95% a normal person. But which I didn't know at the beginning, I developed impulsive behavior. I started, because just after my surgery, we went into COVID. We had a lot of, we went into all this lockdown and all. I used to do a painting every single day. Not a small painting, quite a large size. I have to do it. So I developed this impulsive behavior. Then, that went on for a year. After that, that high went off. I went into apathy, and I lost and I was really a fitness enthusiast. I was before DBS, and after DBS, I was exercising everything. But after 1 year, I went into a dip, and I lost interest in everything. I went into depression, lot of delusions I developed. And then only my neurologist, he said it, I went into, I had actually developed a bipolar disorder. And I underwent all this treatment with antidepressants, antipsychotics, everything. So that took a toll. That was and now I've come out of it. But all these psychological symptoms was not explained to me earlier. That I can develop all this.
Right.
But now I'm well, now I know about it, and I want others also to know that you might develop all these symptoms. And I feel the caregiver should note all the symptoms.
Right.
And they should inform your neurologist or something. But after 2 years, I'm not as, even my motor symptoms have, I was normal, almost 95% normal the first 2 years. But now I've developed a little gait issues and a little balance and coordination. My bradykinesia on my right side is more. All that I've developed now, but I've just accepted because Parkinson's is a progressive disorder. So we have to accept and live with it. Right. But the main crippling thing was the psychological symptoms which I developed after DBS. But the doctor said it might be due to DBS or it might be a normal phenomenon. But I'm not sure about it.
Right. Thank you so much for talking about it. I think it's again one of those things that, it's very important to listen to experiences of lived experiences, because only then we understand some of these. Professor Pramesh, your experience in terms of life after DBS, changes in symptoms, impact on activities, etc.
Actually, my DBS was, as I said, a year back, March. In fact, March 28th, end of March, I got the DBS done. So the first few months are very energizing, and as I said, as we talked about it, lately I am sort of feeling a little demoralized with my gait issues. Some gait issues have come in indoors. When I'm indoors, I kind of walk tentatively and so on and so forth. I have not had a fall, but I sort of it's difficult to maneuver a bit. So that is what I'm experiencing right now, and I'm trying to take care of it through exercising. I do believe that exercising in the right way is absolutely essential for a Parkinson patient, one way or the other. If you don't do it, then you are in big trouble in all kinds of ways. I mean, I got into trouble because, and Parkinson is a way of sort of coming at you from all sides and sneaking up to you. Sometimes your strength becomes your weakness. I probably overdid my exercising last time and got myself into back pain issues, and then that created the cycle of problems. So I'm now being very careful with even my exercising, which I do, so that I don't overdo it. And but that holds me back from my normal kind of, my Parkinson normal kind of sports and things which I used to do earlier. I have taken to a thing called Nordic walking, which is very helpful, which is helping me a lot. And I would like to suggest it to other Parkinson patients as well. Check it out on the net and see how it works, because it gives you two poles to work with. So you can balance yourself and you can conduct your exercising. It's a soft impact exercise. I mean, it's not a high impact exercise. So it kind of works well. It's working well for me. So I'm feeling good about that. I am part of a group, and I did a sort of a survey of other DBS patients who have been, I spoke to, because I knew I was going to be talking in the webinar, so I spoke to them. And some of them, some of them pointed out that they developed complications after DBS, after 2 years, after 3 years. Two of them said they got dystonia after 2 years, after 1 year. And I don't know what the doctors have to say about that. And what Shanti said, that she got depression after 2 years. Well, I'm keeping my fingers crossed.
So Dr. Rupa or Dr. Wadia, any comments on the experiences that both?
So I think, so this is these are some issues that have been very importantly highlighted. What we generally see are the motor symptoms, the on times, the off times, the dyskinesias, these go away. And then what becomes troubling are one is the non-motor symptoms, and the other is gait and balance. Gait and balance is often a challenge, and many times it is there are multiple reasons for it. One is that PD is a progressive disease. With the passage of time, you do expect that these symptoms, especially gait, balance, can get a little worse than it was before. Secondly, we are reducing medications, especially after ST and DBS. We are reducing medications, and medications do help in gait and balance, which only the current stimulation may not be able to do. And very rarely these are stimulation induced. Usually, and sometimes tweaking the stimulation parameters might sort of help it a bit. But most important is, of course, medications and exercise. And this is why that commitment to exercise, I feel that people who have a baseline good activity levels and who are motivated to exercise, they tend to do better on the long term than if your physical activities are limited. The other is, of course, non-motor issues. We know that with our IST and DBS, this is why our pre-operative evaluation actually tries to pick up these issues like low mood. When we reduce medications, decrease low mood, apathy, and this impulse control disorders have a double-edged relationship with DBS. Sometimes we see that people who have these problems pre-operatively, when we use medications, it may improve. But there is also a subset of people, especially young people, who develop these after surgery. And it is usually in the first year that we see this. And this is usually transient. But as it's very important to look for these and bring it out to the doctor when these are experienced, so that one can make medication or stimulation adjustments or add other medications and manage this appropriately. Generally, with impulse control disorders, we see that it's thankfully a little transient. After a few months, or most of the time, it does tend to settle. But these are issues that non-motor symptoms as well as gait and balance. These are the two things that affect the quality of life after surgery.
Sure. Dr. Wadi, anything else that you would like to comment on?
No, I think post-DBS depression is a well-known complication. And in fact, as Dr. Rupa very correctly mentioned, all of us are looking for depression even before we take the patient up for surgery. The reasons for post-DBS depression are manifold. One of the major issues is what happens is after DBS, you're reducing medication. The medication that we're using for Parkinson's already keeps you at a little high on the mood, and that high goes away. But that's not the only reason. There's also a whole psychological issue that until the time that you were undergoing DBS, the equation with the spouse or the caregiver was, whoever was your caregiver, was dominating. after you become DBS and you become physically independent, you resent that interference of that caregiver in ye karo or wo karo. So you feel that you want to be independent. So that equation, and the caregiver also needs to understand it and stop being the over dominating caregiver. So that equation also needs to change. And the caregiver needs to have the confidence to let you do things on your own which you were not doing before surgery. Now, both Dr. Shantipriya and Pramesh were younger people who were not so physically dependent that the caregiver had taken over everything. But by the time many of the patients land up with DBS, the caregiver is literally doing everything. And the patient is just about not even barely managing his own activities of daily living, like khana, pina, sona. That's about all that he can do on his own, or she can do on her own. And then when you become all right, then suddenly, like, the caregiver also has to start letting go of the things that were the responsibilities of their other partner earlier.
Right.
And that equation is very difficult. There have been suicides in the European and the Western world post DBS because they suddenly realize that I've become all right, but like suddenly, like, I have nothing like of my responsibilities or hobbies or friends. And also, that's one of the reasons not to wait too late for DBS, because if you lost all social contact before you had DBS, then it's so difficult to gain it back. I mean, especially because none of the people are like young and in that Facebook generation that you'll generate 100 friends on Facebook instantly. You're not going to. So it's actually very difficult to get friends after a certain age. So it's actually difficult to get your social networks back. So you shouldn't wait till you lose your social networks to do DBS. The later you do it, these problems actually become much more.
Right. So we've also received one question from a live stream. If the symptoms are one-sided, then do you still need to put electrodes on both sides?
Yes. Yeah, generally, because Parkinson's disease, we know it is a bilateral disease. It is maybe asymmetrical and maybe asymmetrical for a very long time. But with the passage of time, we do expect that the other side will also get involved. Also, so it is usually never performed unilaterally. In other diseases like dystonia, if it's a very clear-cut hemidystonia after some lesion, we may place electrodes only on one side. But for PD, it is often bilateral. This because it also has implications for your medication management. When we reduce your medication, symptoms on the other side may become more prominent. So it is bilateral.
Right.
Both sides.
A couple of quick questions in terms of cost and coverage. Dr. Rupa, since you are at AIMS, is that is the cost of DBS covered under any government medical schemes? And approximately what is the cost in a public hospital?
So the DBS is not generally, there are certain government health schemes that cover it. For example, CGHS can partially cover, ESI almost supports it fully. And there are several state government health schemes who cover it for their employees. Patients who are not covered under these, people who have Ayushman Bharat, there is no package as of now for DBS in Ayushman Bharat. And because the cost is often beyond the limit of Ayushman Bharat, it cannot completely cover it, because if DBS is, it's actually a two-stage procedure. In the sense, there is a stage of electrode implantation, and then there's the battery implantation. So one of these aspects of it may be partially covered using Ayushman Bharat for patients who are eligible for that. But other than that, it is the implants are expensive, and in a public hospital setting, depending on the type of the DBS leads, directional versus non-directional, and batteries are chargeable versus non-rechargeable, it can cost anywhere from around 7 lakhs to 15 lakhs rupees.
Right. And Dr. Wadia, in terms of private insurance, do you find that there is coverage, or patients have to go out of pocket for it?
So private insurances have been traditionally covered. So private insurances have been covering DBS. They've been putting caps, and literally it's like fine print. So there are people who say 50% of your coverage would be covered. So if you're insured for 15 lakhs, they give you 7.5. If you're or they will put a limit like not more than 10 lakhs or not more than 5 lakhs, even if your coverage is 25 or 50 lakhs. And then there are those which will give you the entire amount. So it's very variable, and I think you've got to read the fine print. But I think the lesson I've learned is that you must have multiple policies and not rely on one.
Right.
Because at least you'll get a little from each. Because it's very disappointing. Because I'm a lot of patients who told me, oh, I have a good coverage, and then when they actually go back to the drawing board, they realize, oh, there's a fine print there.
Oh, Lord.
And Dr. Rupa gave us an indication, either from Dr. Shantipriya or you, Dr. Vadia, what is the kind of costing in the private sector broadly? I know it can range quite a bit, but
so again, what happens is depends. Like we are in a private center, which is where we are treating patients who want the best. So we are moving more towards using directional lead systems. Directional lead systems are way more expensive.
right.
So a directional lead system in a private hospital for a non-rechargeable will start around 22 lakhs and go up to 25 lakhs if you're having a rechargeable. But a non-directional system can be probably done in even 15 lakhs, 16 lakhs. But most of the systems have actually disappeared from the market. The basic batteries which were there earlier for non-directional have been just phased out.
Yeah, it's
So
post-obsolescence that tech companies do.
So you don't have the Maruti, the 800 any longer.
So
that's the issue.
Right. Yeah, the technology does this post-obsolescence, which is, a big problem. One question which we'd received from somebody was, what is the role of artificial intelligence? Does it improve patient outcomes? Is DBS already using AI?
I'll take that question. So artificial intelligence. So right now we are already having image-guided programming softwares. So we are feeding in the MRI data, the CT data. So we are trying to develop in the programmer, you can actually see that this is where your electrode is. So if you move vertically upwards, you're in a better zone. If you move horizontally this way, you're better zone. So this is already available to us. But I think the future is in looking at imaging algorithms to determine how to program patients faster. Then there is also a new system from Medtronic which is available, which is sensing brain waves. It's already available. So currently we are allowed to sense brain waves, which will tell us that if you sense a high beta band, you know that this is the place that your Parkinson is. It indicates poor Parkinson control, and you can give more stimulation.
Right.
There's what is translated in the next technology in the same system, which is already approved in Japan, is called adaptive DBS. Because what is known is that when you're sleeping, you don't really require a very high Parkinson control. When you're awake and walking and running and exercising, you need more control. So, and based on if you've taken your medication, you need less stimulation. Not taken your medicine, you need high stimulation. So the adaptive stimulation allows the current to go up and down based on the brain waves that are there.
Right.
This technology is not approved in US yet, not in European Union. It's only approved in Japan, and it's just started off in Japan. And I think the main advantages will be to reduce your stimulation related to side effects more than anything else.
Right. Excellent.
So can this be adapted for people who have got this as a device earlier?
So I think it will be only for those with Medtronic leads, because currently only Medtronic has it, and I think it will be mainly with the Medtronic directional leads, but I think the Medtronic basic leads will be allowed to do it to some extent.
Okay. Without extra surgery and all that.
Correct. But I think but again, only when you change the battery.
Yeah. As of now, you need there is a specific type of pacemaker that can sense these, and generally it works with their directional leads.
So it's only when you have Percept Medtronic device and you have Sensite electrodes, But I've had a lot of questions from patients as to which one should we imply. Should we bank on the future of adaptive technology, or should we use the technology which is today? I would say use the technology which is today, because I think adaptive DBS is the pie in the sky. We really don't know where it's going to go, which direction it's going to go, how useful it is. Data is still not out.
And even so, I think the eventual aim is to close the loop of DBS. So that will make the life of the programmer easier, hopefully better outcomes for patients by directly in live real time sensing the brain activity and then tailoring the stimulation to deliver that. So currently, as Professor Wadia said, it can be done with some of the IPGs available and directional as well as non-directional leads. But at this time, the close the loop, that algorithm is not yet there in clinical use, where you can adjust according to the sense. Right now, we can sense, and according to what we see as sensed, we can set the currents. But the sensing driving the stimulation, that loop is yet to be closed in clinical practice.
Yes, so I think I'll differ with Dr. Rupa. Dr. Rupa is of the very positive mindset that it's going to reduce time for programming. I don't think it's going to reduce time for programming. I think none of the technologies that have come have actually reduced time. It's only increased time.
Right. So I think one final, we've gone over time, and thank you everyone for staying on for that extra time. I think I'll go around to each one of you, any final messages to the audience who are considering this or who had it and are either having an issue or not sure whether they are at optimal levels. So I will start with the Dr. Shantipriya first.
Yeah. You can go in for DBS with an open mind. Don't have any expectations at all. And just shake off and move on.
Shanti, there would be no choice. The mind will be opened up.
No, I think you should not go with any expectations.
Yeah.
That the symptom will be fine, I'll be normal, the symptom. You have to go with an open mind with no expectations.
But you can't go with no expectations, right? You have to have some
but you have to have some expectation, not that ideal expectation that will be completely normal.
I think what she means is realistic expectation.
Yeah, realistic. Yeah, that's the right word.
Right. Okay. Professor Pramesh, Dr. Pramesh.
Let me start by my redefinition of Parkinson's, because that will help us to place where you are with it. My redefinition of Parkinson, medical definition, is of course cognitive disorder, progressive, neurological, and so on. Mine is acceleration of mortality through deacceleration of movement and destabilization of movement. We are all dying. We are all going to die one day. Our processes are going to slow down one way or the other. So what the hell? The whole idea is the Parkinson, you have to fight it out, you have to live with it, and you can't beat it, but if you keep fighting, Parkinson will not beat you.
Right.
And if
you have to just shake off and move on.
Yeah, that's it.
And move on.
If you can earn your draw, then you are a winner.
Right.
That's my message.
So you heard philosophical responses from both patients or persons with Parkinson's. Dr. Rupa?
So I like to think of it, I think it is a journey. And I often like to make the comparison with diabetes. Nobody says that who has diabetes says that I have diabetes disease, or I am a patient of diabetes. It is just something, it's a lifestyle disorder, and it is something that I have diabetes. So same with Parkinson's. Although it's called a disease, it is something I think of it as a journey, and we are there, the patient, the caregiver, and the doctors, the entire allied healthcare team are there to sort of walk with you in that journey. And in that journey, there are several options, the medications, surgery, there are additional therapeutic options, physiotherapy, all this plays a very important role. And so we should look at it as that. It's a partner sort of for life, and we are all partners in helping you manage this. So
Right.
I think that concept of it being it should be taken in that sense, I feel.
Right. Dr. Vadia?
Yes, so I think all the three people have said absolutely the right thing. That yes, I mean, you have Parkinson's, you have to do the best to ensure that you have best quality of life. And in this, you have to take the right call as to timing of surgery, if at all you're eligible, not eligible. I think the most important thing, I think I would say that the decision whether you're eligible or not is from a neurologist. You cannot expect the neurosurgeon to decide you're a candidate for DBS or not. The neurologist has to decide you're a candidate for DBS or not, and then you take the plunge. So I think that's one of the things. And the second thing is, don't wait too long until your quality of life is so poor that then even when you get better, you're literally struggling to even get your friends in order. You're struggling to get your social life back in order. So do it when things start to get difficult, but not until they got so difficult that you're completely, I mean, it's very difficult to get out of it again.
Right. So thank you, everyone. I think we've talked of the benefits. The panelists have highlighted the risks. The importance of the timing is clearly very important. And clearly it is a shared decision with, that patients and family members have to take with the neurologist. So I think for anybody listening to this, remember that you need to make informed decisions. And there are not just, we've not, I think, touched on all of the issues, but as I think the panelists highlighted, the social support is important, the choice of device is important. There are decisions even on the device in terms of, obviously, how much you can afford plays a factor, but there are benefits and, not risks, but constraints associated with different devices. So I think it's important to consider all of that and make informed choices. And as Dr. Vadia said, that decision needs to be made with your neurologist. So, and as we can see from both what Dr. Shantipriya said and Professor Pramesh said, that they went ahead knowing the risks and they would still say that you should go ahead because it does help in the journey of Parkinson's. So thank you once again to each one of our panelists for taking the time to talk about this difficult decision-making process, as well as a complicated topic like deep brain stimulation being explained in simple words to the audience. So thank you, everyone, and we hope that it helps people make better choices.
And thank you, Aparna, for giving us this opportunity. Thank you for providing us the platform. Thank you.
Yeah, thank you so much.
Thank you. Thank you, everyone.
Thank you.